And a good evening and welcome to MedStar Health Physical Medicine and Rehabilitation Webcast. You're watching us on Facebook Live. I'm Jamie Costello from WMAR ABC 2 News. I'll be your host here tonight. And we are streaming live from the inpatient rehab unit here at Good Samaritan Hospital. Look what they've done for us. It looks like a hospital. Look at this. We've got crutches, we've got a walk, we've got everything needed to make you better. And all you have to do is watch from your own home here tonight. You can also submit questions. We've got a panel of great experts. When's the last time you've been called an expert, Doc? That's pretty good. You are an expert just this morning. Listen, we've got a crowd full here of people that have crammed in here to watch and listen and to learn, and we're going to make you feel better over the next hour. And of course, we want you to get on Facebook Live, put a little like on there, and if you have a question, put it on there so we can ask it right here. So if you have any questions at home, just click a like and be sure to share the post so your friends know that what we're doing here tonight, Facebook Live. We want to start with Dr. Scott Lepre, who is the chair of the program here, as well as the Associate Medical Director of Regional and the MedStar National Rehabilitation Network. So we'll get right into it. Physical medicine and the rehab. Fit it all in for us, Doctor.
Physical medicine and rehabilitation is the branch of medicine that focuses on improving quality of life by restoring function lost to a variety of illnesses or injury that might have affected anywhere on the body from the head down to the feet. And as part of the MedStar National Rehabilitation Network, we are really uniquely positioned to be able to draw on over 40 years of experience and expertise in the field of rehab in order to accomplish our mission of adding life to years.
And how does this differ from a skilled nursing facility?
Sure. So the main differences between what we do here in acute inpatient rehab and what occurs in a skilled nursing facility has to do with both the acuity of the medical issues that we are able to manage here and in the intensity and the breadth of the therapy programs that we offer. Someone who is admitted to the inpatient rehab program here can really expect to receive top-of-the-line medical care and a truly comprehensive therapy program.
All right, Doctor, thank you very much.
Sure.
We'll be, of course, spending more time with the doctor here as we go along here in the next hour. Let's bring in Carol Zeller. Carol is the patient care manager here on the unit, but also a very personal insight in this inpatient rehab program. Tell us about that, Carol.
Sure. Back in November of 2012, I, as a parent, received a telephone call that no parent wants to receive. My oldest son, Adam, who at the time was 18 years old and was away at school in Virginia, suffered a near-fatal brain aneurysm rupture. Basically, one of the arteries in his brain had ruptured and was bleeding. So he underwent about 10 hours of surgery, followed by 2 weeks or so in a neuro-intensive care unit in Virginia. When Adam first came out of surgery, he was not breathing on his own. He was in a coma, and within a few days did regain consciousness, but could not move his left arm, his left leg, had cognitive issues, wasn't able to swallow well, and has lost about 50% of his vision, as well as some memory issues as well. So after the 2 weeks in Virginia, we had to decide where to transfer Adam and getting him closer to home for rehab. And my husband and I never had any question about where he would go. He came here. And not because I work here, but because I knew that what we would provide here would be the best care he could get. So one of his primary therapists is here with us today, Jen, who we are so indebted to. And they worked so intensely with him. And as you can imagine, we didn't leave his side the first couple of weeks. But after we got here, we could go home and we could get some rest. And we have a younger son, Noah, who we could spend some time with. And we knew that he was in good hands when we left. And so it was an incredible experience. And I have been fortunate to be a part of this MedStar Good Sam team for a long time, but never probably as fortunate as I was back then. So Adam continued after 4 weeks here in inpatient rehab. He also attended our outpatient network through NRH, and also went through our adaptive driving program here at Good Sam and was able to drive again. And in September of 2013, actually returned to college and he will be graduating this May with his bachelor's degree in civil engineering. And actually, Adam is on spring break this week, so he's here with us today, just kind of supporting Mom and also demonstrating what we're able to accomplish here at Good Sam.
How did you tell that story without crying?
It's really hard. Watching him, it's hard. But it's life. It's what we've dealt with. And if I could share that and other people learn from it, then, and they learn what's out there and what's available and what can happen, you know, that's all I want to do.
Adam, raise your hand so we can catch you on camera. You know what? I'm going to move this thing here. This is ridiculous. This is... Adam, how old was he?
18.
Look at you. Look at you. That's what Good Sam did?
Yes.
That's what he did.
Jen, unbelievable. What a job. Unbelievable. You're doing great.
Yeah.
You're driving. You're going back. What are you majoring in?
Civil engineering.
Come here. Come here. Can you come up? Come on. Come on. What the heck? Look
He's
at
going
that.
to kill me later.
Is this a
Jamie.
miracle? Yeah, hold on.
Yeah.
So do you consider yourself a miracle? I know you're not Mike, but the heck with it. Go ahead. I'll lean in. Do you consider yourself a miracle? Go ahead. Don't be humble.
Yes, sure. I mean, that's what everybody says, but I mean it's
how
just,
bad was you had the brain aneurysm? I mean, you could barely function, right?
Yeah, it took probably a week before I could actually sit up. I had to learn how to walk, talk, eat, smile. I mean, I couldn't move the left side of my face. Yeah, it was rough, but without Good Sam, none of this would have been possible. That's for sure.
Well, how about a hand for this guy here, Adam? Good luck to you, man. Take it with you. Here, that's a souvenir for you. Mom, what do you say to this? The place you work.
Yeah.
See?
I'm telling you that nothing happens by chance.
Yeah,
I tell
I'm
people
just
that.
gonna tell you
That's
that.
why I'm a rehab nurse. That's why I work
exactly
here.
right. And this place saved your son's life.
Absolutely.
Adam, way to go. Have you met Eve yet? All right, keep that down.
A few more months.
Wow. That's it for tonight. Thank you for joining us here. Man, only the dog can top
Yeah,
Adam.
exactly. There you go.
Yeah. All right. Thank you, Carol. Maggie Lister has a doctorate in physical therapy and has been part of the inpatient rehab unit for the last 12 years here. What is the objective, Maggie, of the physical therapy, and how can it help patients who have suffered, like Adam, from a stroke or even a spinal cord injury?
Yes, so in this setting, our goal is basically to restore function, increase their mobility, basically promote health and wellness. And we do this by just basic skills of learning how to get in and out of bed, how to get in and out of a chair, get into a wheelchair, learning how to use a wheelchair, being proficient with the propulsion, learning parts management of the wheelchair, and getting patients back to walking again. And we do this by prescribing an exercise program. In fact, in the patients that I've seen with spinal cord injuries and strokes, if they're very debilitated, have a lot of weakness, our biggest thing that we start working on is learning how to propel a wheelchair. If they have pretty good upper body strength and function, we learn basic wheelchair level skills, propelling the chair. As you can see, Chris over here is demonstrating his ability to go up and down a ramp and then doing a wheelie, which is a much more high level skill. It's not something that we're going to learn right away, but is something that we will eventually get to. Chris also demonstrates in this video the ability to jump off and on a curb. So that is not an easy skill to learn. He was a great patient for us there. A patient is also very weak in their upper body and they have difficulty with being able to propel a manual wheelchair. We also have a great variety of demo wheelchairs, power wheelchairs. And again, Chris is demonstrating for us here on this video hand control function, so he does have hand control. If a patient does not have good hand function strength, we have other options where they can control the wheelchair with their head. They can control it using their chin. Right here is the chin switch. Chris is driving the chair using his chin. And then there's another system via a straw, which is called a sip and puff wheelchair. So this way, patients can have independence. Even if they can't move their body by themselves, they are able to get around their room, be able to come and drive themselves to and from therapy, which is very important for our patients to be able to control some part of their environment here while they're in rehab. If they're are able to do some standing and walking, but yet they might not be stable and strong enough, we also offer body weight support system, which is research-based. It has had a lot of research showing that it improves patients' ability to be able to stand and be able to walk at a normal pattern, which is nice because a lot of patients are unable to support themselves initially when they first are injured. And this way it allows the therapist to really focus on getting their walking to be more normal as it's supporting their body weight. So it makes it safe for the therapist and it makes it safe for the patient also.
So when you started out in this line of work,
Yes.
did you see these advances this soon? All the wheelchair and the innovations that we've seen now?
I'm telling you, it's an ongoing learning.
Wow.
In this environment, and that's why I love being here in rehab. We have a lot of options, and in fact our new rehab that's being built, we're getting this 0G, which is an overhead track system that is going to allow us to do a lot more mobility with our patients, be able to go up and down curbs, be able to go up and down stairs with it. So it's an evolving thing, and it's an awesome job to be able to continue learning and be able to promote this health and wellness to your patients.
Oh, great job. Great job. Thank you, Maggie. That's great. And it took you, you go to school 7 years?
It took 7 years of college, yes.
Wow, you're still learning.
Still learning though.
So you're still teaching. Way to go. Getting people mobile, of course, could be walking, rolling, or even in a vehicle. Meredith Ufstead is the physical therapist. Now, you can't train patients to get in and out of a truck, here, can you?
Hi, yes, we can. I'm glad you came over to join us with the truck. The truck we use here to practice getting in and out of as we're going home, because the biggest day really is the day you get to go home. So we want to make sure you can get in and out of your car and be ready to go home and continue your life. Jamie's going to demonstrate how to get up and get into the truck for us. So Jamie's going to stand up. She's going to use the walker and head over to the seat, backing all the way up, so that she can feel her legs on the chair, on the truck. She's gonna reach back with her hands for the seat and possibly the dashboard, depending on the car or the truck. We're gonna move the walker away from her and she's gonna swing her legs in. Now, while we're also here in the truck, Jamie can practice putting on her seatbelt. That is something that is difficult at times when you have an injured arm, and so we practice that as well. Jamie's going to let go of that seatbelt and she's going to demonstrate how to get out of the truck. She'll swing her legs out, scoot to the edge, and push up from the seat or the dashboard, never the car door. And she's going to come back on over to her wheelchair. We also have other things here at Good Sam to practice with. We have our bathrooms and our ADL apartment, and that's a place where folks can go and practice getting in and out of their tub or their shower, just like they have at home. We also have an apartment here that we has a full kitchen, lets folks come and practice making meals, practice getting in and out of a regular bed, and really practice all the skills necessary to go home. Thanks for joining us over here at the truck. We're glad to have you.
That is incredible, isn't it? Things we take for granted. And here we have a practice. We can practice getting in and out of a car to get our lives back. That's unbelievable. Hey, Maggie, let's bring you back in here. Show some of the, I see you're going to have a video to show us.
Yes. So other options that we have for our patients to really work on some strengthening their weakened muscles is electrical stimulation, which is actually an electrical current going into these muscles and nerves. And Jen has a video that she demonstrated with our Bioness L300 Plus, which we are the only inpatient rehab in this state that has it. So if we can go to the video and you'll be able to see Jen is able to speak on it.
So this is an example of a person with hemiparesis, so that would be weakness on the right-hand side of their body, and how walking might look. With this example, Teresa has weakness in her ankle, so she's having difficulty in dragging her foot forward. And as she's standing on her leg, she has weakness in her quadriceps muscle, or the muscle that straightens her knee. And that's affecting her balance, it's affecting her efficiency and her gait speed. With our Bioness 300 Plus unit, we're able to both control the ankle and the quadriceps muscle. We're the first unit in the state to have this unit. So we're now able to control both the ankle and the knee while she's walking. And we know from research that people that walk at more normal gait speeds have less falls. They're more comfortable with getting out in the community. They're less likely to be homebound. So it's a really effective means for both for our spinal cord population as well as our stroke population.
Way to go. Now, Maggie, that's a computer generated for the, so explain the machine again.
I'll actually let Jen speak on that, because Jen actually is a pretty good expert on the Bioness.
It has a computer system in it, and it has something called an actuator. So as your knee is moving and as your ankle is moving, the computer already knows when to turn the muscle on to pick up your foot, and it also knows as your heel is landing to turn on the knee muscles as needed. So we can either do the quadriceps muscle or the hamstring muscle, depending on what is needed. And then we can also change how much the timing of it, and so it's been a very effective means for us. We've had other units before, and this is an even better unit with being able to control the ankle and the quad.
Nobody else is doing this, right, Jen?
Well, we're the first in the state as an inpatient rehab unit to have it.
All right, let's go to Teresa Dolan. Teresa is senior occupational therapist who has been here 20 years. And Teresa, explain to me the difference between PT and OT, right?
I'm an occupational therapist, and in occupational therapy, we work with individuals across the lifespan. Of course, here at Good Samaritan, we work with adults, so 18 and up. And we use functional tasks or daily activities, which are what we consider occupations, in order to have people recuperate and recover from injuries and illnesses. So when we do when we do our evaluation, we look at multiple things. So we're looking at a person and seeing how they're able to move their arms and legs. Do they have weakness there? We're looking at their sensation. We're looking at their cognitive or thinking skills. We're looking at their visual skills and their perceptual skills. And we're looking at how all of those things impact their daily activities. So I like to tell our patients here that we work on anything they do from the time they wake up till the time they go to bed. So in this setting, because we're looking at trying to get somebody to go home, we're looking at patients being able to do their bathing and dressing, their toileting, their toilet transfers and tub transfers. And then depending on what they need to do when they go home, we may even be able to work on cooking skills and other tasks that they would have to do around the house. That would continue in outpatient, that we might look at return to work and the skills that would be needed for that. So let me give you an example of what we do when we look at a task, because even though somebody might have trouble feeding themselves, that trouble could come from a variety of things. So one patient, when we observe them and we do what's called task analysis, we're looking at why they're having that problem. One person might have difficulty bringing their hand to their mouth because they have arm weakness. So we might be working on that with one patient. But another patient that might have trouble feeding themselves might have trouble seeing where that plate is or seeing where their fork is. So we might work on changing the environment by increasing contrast, so that they're better able to see their environment and then feed themselves. Another patient might have trouble figuring out that maybe they're trying to eat their soup with a fork instead of a spoon because they have difficulty understanding the difference between the utensils and how to use objects correctly. So as an occupational therapist, we're looking at all of those things, honing in on what that individual patient's problem is, and working on it from that skill level.
We're all in time sensitive. So how long does it take? I know everybody's different, but how long does it take to learn how to walk again, to learn how to do a daily function like wash yourself again? Is there,
that's a great question, and it's a question we often get from patients. How long is this going to be? Am I ever going to get back to where I was before? And for each individual patient, all of us on the therapy team and our physicians and our nurses are giving different answers, but similar answers, because we don't have a magic wand, and we don't have the ability to exactly predict, but we can give some general ideas of what patients are able to do when we give their evaluation. we like to not just look at what's wrong with them, but what's right. Because everybody has strengths, and we can't forget to really focus on those strengths as well.
I like that. What's right with us instead of what's wrong with us. All right. If you have any questions, if you're home right now watching us on Facebook Live, you can hit us up right now. You can ask a question to one of our great experts here. I mean, where do you get this chance? Like right now. So get online and send us a question in here and try to stump the panel if you can. I don't think the doctor will be stumped, though. All right, which brings us to Nash. Jamie, Nash is not a therapy dog, but a facility dog. Explain that for us.
A therapy dog also serves an amazing purpose, but they are typically superficially certified. They're handlers or owners or volunteers that are going into facilities and visiting with patients in a more unstructured, emotional way.
All right, how old is Nash? Tell us everything.
Nash is 4. He is a graduate of Canine Companions for Independence. He's been with us here at Good Sam for about 3 years. He's a mix between a golden retriever and a lab. He's devastatingly handsome.
Hello, Nash. Look at that. And he's got a wet nose.
And what is so great about Nash is one of the most important things we need to do with our patients is get them motivated and ready to participate in therapy, even though they're going through something quite difficult right now. So without even working with Nash, just seeing them, they come into the gym, their faces light up, you can see the stress go away, and they are primed and ready to get to work. So just his existence in the gym is a benefit. But to give you a more structured example of what he does during the day, Teresa, why don't you come over here and you can act like my patient and work with me and Nash. So Teresa kind of described what task analysis is. She kind of broke it down in terms of what we would work on so patients meet their goals. So let's say one of Teresa's goals is to be able to put her pants on. In order to do that, she needs to have good balance. So in this activity, Nash, sit. She's going to work on standing and bending and reaching to give Nash a toy or any kind of object so that we're challenging her balance. So she's going to go ahead and reach. Good. Nash, get. Yes, good boy. And now I'm going to take him a little bit further back to challenge her a little bit more. Nash, sit. Yes, good boy. Yes, good job. So she's working on standing unsupported. She's reaching outside of her base of support. Those are all things that we need to do when we're trying to put our pants on and stand up. So another one of Teresa's goals is to be able to get to the grocery store because she's the primary grocery shopper in her house. So we know that when we're grocery shopping, we have to push the cart, and the cart is heavy. So she needs to be able to have the endurance and the strength to walk with something and push it so she can get through the grocery store. So in order to work on that, we can go, Nashie, come on, up. Go ahead, bud. There you go. Good job. All right, Nash, ready to go for a ride? So we're going to take Nashie for a little joy ride. He loves this because he then gets to be king of rehab. And we're just going to walk down here. So Teresa's working on her endurance, her balance, and this is going to get her back at home so she can be the boss of the house getting the groceries. And we're just going to turn around here. Good boy. Yes, you're being a good boy. I know, you're being so good.
Nash will be calling an Uber driver here in a minute. Look at this. This is great.
And then, as Teresa also explained to you, OT is not just about motor and physical activities and sitting and standing. We also work on cognition and vision. Nashie, jump. Come on, bud. One of the pieces of cognition is being able to sequence and organize a task. So if we don't know the steps that are included in putting on our shirt or getting dressed, then we're not going to be able to do it independently. So one of the things we can have a patient work on with Nash, you come here, sit. Good boy, is trying to get him dressed. Because here she's trying to get somebody else dressed, and it might be a little bit easier for her to sequence that before she attempts to do it on herself. So now she's just going to sit here so patiently while he gets dressed. As you can see by facial expressions, this is his fave.
Get out.
Oh my goodness.
Nice job. Good boy, Nash.
Fix your collar.
Fix your collar.
There we go.
Excellent job.
Yay.
So that's a little taste of OT with Nash. We're going to throw it back to you, Jamie.
All right, Jamie. Thank you. She spells her name wrong. I don't know what happened. That is great. All you dog lovers, anybody have a dog at home? No way can our dog do that. That is great. Nash is well trained.
And Jamie, he's also available for birthdays and weddings.
Get out of here. No kidding. You rent them out?
We do.
That's great, I bet. Catch the garter. What really matters here is independence. Not everybody may have a highly trained dog like Nash, but there are other technology advances that we've seen out there that can really help us get to a level of independence. Let's watch.
With a normal tremor, if my food starts to fly. With Liftware, which is a technology that you can purchase, when I have a tremor, I can come in, but the spoon has a little microcomputer in it that keeps the food on the spoon, allowing for Parkinson's patients to have better ability to feed themselves and more quality in their life. Patients who have difficulty moving their arms or their wrists or forearms sometimes have difficulty keeping the spoon level when they come up to feed themselves. The leveler will level the spoon for them so that they can get the food to their mouth. So I'm going to just show you by coming up, and you'll see that as I come up, the spoon bends. For patients who have, or people who have low vision or difficulty reading labels, this comes with this device, and you can wear it around your neck because it's got a nice lanyard to it. And then you can either use these little magnetic clips, or you could put on these little dots, stickers that come with it.
Chicken noodle soup.
But then if you were on your own in your kitchen and you weren't sure what that label said,
Tuna fish.
it says it for you.
Chicken noodle soup. Basil.
Sometimes even seeing what kind of money you have in your hand is difficult. So this little device will do it for you. And all you do is slip the corner of your money in, press a button,
5.
and it will tell you what the bill is. There's an app that you can download that will do it for you.
$1.
Sometimes people have difficulty standing up. Obviously, in occupational therapy and physical therapy, we work on people getting stronger so that they get better with those skills. But for some folks, they just have hard days. Sometimes everybody just needs a helping hand or a helping lift. And that's what this does. So you add this cushion to your chair. You don't have to buy a brand new chair. And by the push of a button, you get lift off. Sometimes people have memory problems and it's hard for them to remember to take their medications. Let's say you're supposed to take the medication at 12 o'clock. An alarm can be set on this so that it will go off when you need to take your medicine, and then you simply flip it forward, the medication will come out, and you go ahead and take it. The alarm doesn't go off until you flip it, so that is how you can remember to take that medication. That medication box is locked, so you can't go and take too much medication at any one time during the day.
Well, that's the greatest thing I've ever heard, because I had a father. My father was, every time he went to sleep and he woke up, he thought it was a new day, so he'd pop a pill. You know, he was out of his mind, and we found out he was overdosing. That is a great invention. Great. Thank you. Hey, listen, here's the deal. When you're here at Good Sam, and then you get the orders that you're going home, that can be scary as hell. And I tell you what, Teresa's back with us, and we're going to go over to Teresa's apartment. Let's all go in. Teresa, tell us about the apartment living.
So the apartment is a great thing that we have here at Good Samaritan Hospital. And when we initially got the apartment, we had two kind of concepts in mind for it. One was for the patient who had a traumatic injury or illness and was going to need a lot of assistance at home and was going to have caregivers or family members taking care of them. And while we do training individually during our sessions, and they may practice transfers and family members may get very good getting them in and out of bed and doing all the things in isolated tasks, by putting somebody in the apartment overnight or for 24 or 48 hours with their family member or caregiver, that caregiver and the patient get an idea of what it's going to be like to go home. So we can set them up with food in the apartment so they still have to do whatever cooking needs to be done. They get a really good picture of what it's going to take to do something for a full day.
The stove or the oven?
It's a full working apartment. So
Yeah.
it's got a kitchen in it. It's got a full bathroom with a bathtub. We really made things so that it wasn't 100% accessible.
Okay.
Because our homes aren't 100% accessible. We have a regular bed in there, so but we can also have the opportunity to move a hospital bed in if the patient's going to go in home in a hospital bed. There's a living room area with a sofa. So it really is a home setting. That patient and family member can be in that apartment and they still have the support of us. So they're, the apartment is right on our nursing unit, so they have care 24 hours. But they have, they're really responsible to kind of take care of their loved one.
When you go home, do you find that some of the patients get bed locked? Like they're just going to get in bed and stay there?
Well, that's what we really try to avoid while they're here. We really reinforce that that's only going to set them back. So the other patients that we put in the apartment are patients that might be going home by themselves. And while we might have confidence in their ability to do things, they might not have confidence. So by putting them in the apartment, it's a way that they can kind of test themselves. So for example, they need to get up in the morning. They need to be able to get themselves ready. We're not going to put them in there if we don't feel that they're really independent with things. But it's also kind of a test so that, for example, we might have it set up so they have to call in order to get their medication. So are they remembering what they're supposed to take? And are they able to tell the nurse that? They may have to do their bathing and dressing on their own. So sometimes the therapist will let them do it on their own, or we might come in just to observe, make sure that they're not having any difficulty, but really kind of stay in the background so that they have to do it on their own. So they're doing everything they need to do in order to be able to return to their home setting, but they get to, again, do it in a setting where they feel like they have the support there to give them the confidence to take that next step.
You see a lot of anxious people, don't you?
Oh, we absolutely do. We absolutely do.
All right. Well, let's bring Carol back. Carol, now you're not going to play the role of mom. You're going to play the role of nurse, which you've done admirably for 30 years here at MedStar. Good. Can you explain that if we're a patient here, we all should look for the nurse that is certified inpatient registered nurse?
Yes.
Why is that so important?
Well, you hear about other specialties. You hear about an emergency room nurse. You hear about an ICU nurse. But I think a rehab nurse is somebody you don't hear about that often. And really, as has been said by some of my colleagues, we are specialized in looking at patients who have maybe short-term or progressive or long-term disabilities, and how can we help them to facilitate their highest level of functioning. So we may address things like skin, their bowel issues, bladder, diet, swallowing, you kind of name it. Plus we also will take what's been going on in therapy and will reinforce that information with the patients on the unit. As far as a certified rehab nurse, we have been blessed that I have about 20 certified rehab nurses here in my program, which is a large number in comparison to a lot of our competitors in the area. And what that requires is that you need to have at least 2 years of experience in the specialty. You need to have recommendations from fellow certified nurses, and then you also must take a national computerized exam. And it really is a testament to their knowledge base, their dedication to what they're doing and this practice. And I also just think it's a way in which we can allow and help our staff to grow, because part of being a certified nurse, in order to maintain that specialty, you must obtain a set number of continuing education hours. So that really keeps our staff abreast of what's going on, up to date, with the knowledge of what's happening in rehab nursing, and allowing them to be lifelong learners. And I've been fortunate enough to work in this facility where we promote that. We help to support them getting the education, and they're really proud of what they do, and I'm proud of what they do. And so I think that this is one way in which we can help to recognize that.
Great. It's almost like you're a coach.
Absolutely.
You see something that works, and you keep working on that, and then you bring them around. That's great. We're going to talk about speech therapy. You want to talk about the speech therapy?
Absolutely. So as a rehab nurse, we collaborate a lot with our the other disciplines, PT, OT, and speech. And oftentimes there are patients in our program who may have dysphagia or swallowing issues. And we often will collaborate with speech language pathology. And speech pathology will utilize a lot of different modalities for how to deal with patients and work with patients who have swallowing issues. So we are going to now see a video on one of those modalities.
We have a lot of different ways that we can strengthen a swallow, and one of the ways that you'll see here today is we're using vital stim therapy or electrical stimulation for swallowing muscles. So we know our muscles work off of electrical impulses, and this treatment will provide those electrical impulses to stimulate a swallow.
All right, let's bring in Stacy Walker. Now, Stacy's been here since 2010, and she has a master's in speech language pathology. You specialize in neurogenic communication disorders. What is that?
Well, it's an array of communication disorders. They're typically acquired disorders from something such as a stroke. It could be anything from dysarthria, which refers to slurred speech, muscle weakness or incoordination of the muscles, apraxia, which is a motor planning disorder, where people have difficulty with voluntary movements to shape their sounds into words. Also, it could be aphasia, which is a difficulty with language, so finding the words we want to say. And aphasia actually also affects an individual's reading, writing, comprehension of language, but oftentimes that person's intellect is intact, so you can imagine how frustrating that can be.
Oh, man. Now you want to talk about the speech language therapy and stroke recovery.
So we just talked about some of the speech disorders, but as you could see from the video, we also treat swallowing as well. So many of our patients after a stroke might have difficulty swallowing. They may need exercises or the modality that you saw, vital stim, being used in order to safely swallow so that the food or liquid doesn't enter their airway or their lungs.
Where do you start? Let's take a stroke victim. Where do you start to get them back to speaking? Where does it all begin?
So, I mean, we go in and we do comprehensive evaluations. So we look at their motor speech function, their swallow, their cognition, because that's often a good indicator of how well they may do with their recovery if they're able to sequence and execute some of the strategies and exercises that we're giving them. And we kind of start from there.
Okay. Listen, we're on Facebook Live again. If you have any questions, we just received a question. If you can put that back up there, Deborah. It was a question from Brenda. It was a great question. How do you get the family involved? When the patient's leaving home, how do you teach the family what to expect when mom and dad come home? Doc, why don't we start with you, Doc?
Sure. So obviously, most of us have an extensive support network, and if a patient comes with that support network, it's a critical part of what we do to train them to be able to help the patient accomplish whatever goals they have. So we will certainly encourage family to come in, participate with PT, OT, speech, nursing care, medication management, and teach them any skills that we feel they need in order to be successful. If a patient doesn't have that family support, then obviously we're trying to get that patient to a different point, get them to be independent and safe in doing so.
Okay, now we're on Facebook Live. We have a poll question right now. Stroke can cause difficulties in remembering and recognizing. True or false? You can put your vote in right now. True or false? And the Russians are not involved in this one, right? They are leaving us alone. Let me go to Dr. Lauren Connolly. There's been a lot of work. She is a licensed clinical psychologist, and there's been a lot of work happening on this floor to help patients recover physically, but there's a psychological effect that we should not ignore, right, doctor?
Yes. I'm over here, Jamie.
No, that camera. I never take my eyes off that camera.
Okay. Yeah, so there have been a multitude of studies that look at the connection between the mind and the body, and it's very clear that somebody's mental state and psychological outlook will have a huge impact on their health and how they recover from any of these major medical events.
So when do you come in?
So here on the inpatient rehab unit, psychology really plays two major roles. Number one, we act as a consultant to the whole rehab team. So I'll get a consult because somebody's noticed some symptoms that the patient may be exhibiting anxiety or stress, or even just like simple adjustment issues. And then we'll evaluate the patient. We'll determine, are they having any adjustment issues? With any sort of major medical event like a stroke or an amputation, it's very common for patients to have adjustment, and sometimes symptoms of depression or anxiety will develop, which again can be even somewhat normal, a normal reaction to a major stressor.
How do you do it, doctor, when you feel the patient is, I just can't do this? How do you turn that around?
Well, that kind of plays to the sense of resiliency, which I think someone was talking about too, which is a patient's confidence in being able to overcome adversity and having that sense of efficacy that I can get better. And so, yeah, you'll work with them, help them develop coping strategies. If they're anxious, you can teach them relaxation strategies to help reduce anxiety, talk about previous challenges that they've been able to overcome, what helped them then, stuff like that. Treat depression. We work really closely with the whole team. So if there's something above and beyond a normal adjustment reaction, something that maybe warrants more of a clinical diagnosis, then we'll communicate very closely with the team, and maybe medication will be recommended or more ongoing counseling will be needed to just really help the patient overcome that.
All right, being personal, what's it like to send somebody home successfully and find out years down the road, man, they are living the life like Adam is right now? What is that like for you?
That's so rewarding. I mean, he's a perfect example of a great success story, and his quality of life, speaks for itself. I mean, he's well adjusted, he's smart, he's successful, he's achieving all the goals that, any therapist and any mother would be so proud of. I mean, it's so rewarding. I couldn't ask for anything else.
All right, doctor, thank you for the great work. I'm telling you. All right, Carrie Wells has got a question. How do you deal with physical therapy patients who have been through a traumatic event and have emotional challenges that might impede their recovery? Give it right back to, yeah, there you go. Son of a gun, that's your question.
Oh, how do you deal with?
How do you do it?
So when somebody does go through a traumatic event, like say a car accident or something, they can have some, anxiety. PTSD is an anxiety disorder, so we'll evaluate that. Again, we'll work to see if any medication is needed. We'll help them develop coping strategies, utilize their support network. If they're having trouble sleeping, sometimes if you're stressed, your sleep is impacted. We'll work to help improve sleep. Pain management. Pain can also have a big impact on patients' well-being and mood.
Thank you. Let me go to Diane Jacobs now, who is the Senior Admissions Liaison here. She has been here over 30 years. Who's here first, you or Carol?
Here first.
Oh, wow, beat you by a couple days, huh? You started the first traumatic brain injury program in Maryland back in 1983. You started it. What?
I was part of a team.
Well, come on, don't be humble. You started it, all right? Just come out of it. What advice do you have for families looking for quality therapy program like what we have here?
One of the biggest things I see out there when I'm talking to patients is a lot of times they are looking for a program, and many times they might choose convenience over quality.
Okay.
So I talk to them about, this person's going through a major life-altering event, and it might take quite a while to recover, and I would think that you would want what's best instead of what's convenient for the family member.
How do you get here? How do you get in here?
Oh, it's very easy, actually. Whatever hospital you happen to be in, all they have to do is talk to, everybody has a case manager or a social worker, and all they have to do is just ask for a referral to Good Sam's Acute Rehab, and we take it from there. It's pretty easy. We will check into the insurance, see if it's covered. We interface with the medical team at the facility that they're in to see when they're medically ready. We have interactions with the acute therapists. They're in the hospital, see what their function is like there and what their previous situation was, and see if we have goals and work to bring them in.
Okay. I want to go back to Carol because you've been on both sides of the fence here. Guide us through it as a mom first and then as a nurse second, what they did here for your son, as we saw earlier. But again, just expound on that a little bit more, Carol.
I think I always knew what we had was special. You know, in working with patients, seeing them, as you talked earlier, you know, they may go home and then we'll see them come back later and we realize how much they've gained, and you're thinking, oh, I had a piece to do with that. Being on the other side of it, you know, people didn't treat me as a nurse. They treated me as a mom. They treated Adam like they would treat any patient. So it wasn't as if he got any type of special care. It was just what they do every day. Somebody asked him earlier if they thought he was a miracle. I think you asked him if he thought, and I do. I think that this institution, our extended network of the NRH outpatient, our driving program, I mean, all of them, and Adam's, of course, resiliency and his faith, I think, has really been the testament to, you know, what you see today.
Can everybody be repaired? We go down the line. Can everybody be repaired?
So patients wouldn't come here if there wasn't a capacity to improve. Does that mean they're going to get back 100% what they were prior to whatever happened to them? No. But one thing that I think that we do really well here is that we set people up for success. So, for example, the person who might be really anxious, we set it so that when they do something in therapy that they're successful with it. And then we up the ante a little bit so that it continues to let them have improvement. And they're not going to be perfect when they leave here. We consider it a continuum of care. So when patients leave here, they might get home health or they might go to our outpatient setting. And that therapy is going to continue. And sometimes even after the therapy ends, for insurance purposes or whatever, there's still research things that people can participate in, so they continue to make improvements. Particularly, for example, with stroke. The research has shown, and we tell our patients this all the time, you know, we used to say you have 6 months to recover, and then that was increased. You have a year to recover. Now we know that years out, people can still make recovery. It's all about continuing to work.
Maggie, what's it like to see someone who can't walk?
I have had several patients that have come back and visited after they have left here, and they've come walking up to me and said, you know what, I left at a wheelchair level and look at me now. And I say, this is the reason why I do what I do, is to have that experience. In fact, Jamie and I just this week had a patient that came back and visited, and he, when he first got here, he couldn't stand, he couldn't walk, and he left rehab and he had to use a walker. And he just strolled in with his wife, walking just like you and I would. And that, to me, is the best feeling in the world, to be able to have a patient to come back and say, look at me now.
And how about someone who mumbles, all of a sudden can speak the word again?
It's wonderful. It's incredible. I mean, you can imagine that our communication really connects us to people.
Yes.
And also in these situations, you know, it's important to be able to communicate your wants and needs, you know, and be a part of that decision-making process for your own health care. And it's really great that we can facilitate that. We also do a lot with our patients' education and health literacy. You know, we do stroke education courses here. We also have a lot of support groups. We have a stroke support group. We have an aphasia support group that we not only work with our patients but also their loved ones in teaching them supported communication techniques and how to effectively manage that at home.
We get a lot of questions online. Here's one. My mother is not very active and forgets when I visit her or calls. What can I do to help her get active and improve her memory? This is home care. Anybody want to hit on that?
You know, keeping a calendar or a daily planner and writing things down. You know, it's often helpful even to write things down after they happen, that you can go back to it. If you have a loved one who isn't remembering things and you go to visit them and you're asking them questions, you know, what did they do? And the answer is constantly, I don't know. It's kind of a one-sided conversation. It's not really a quality conversation. So if you do things like write things down and have other visitors and other people also write things down, then you can refer back to that information, and it often helps the patient recall what happened and more specific details.
Doctor, I was fascinated how you got in this line of work. What led you here?
I can think back to a very specific day when I was a medical student at Georgetown, and I was doing an orthopedic rotation, and we had a lecture on gait analysis, on walking, that was given by a physiatrist, by a doctor in this field. And the way that she thought about problems and the way that she pursued the solution to the problem just really resonated with me. And as I learned more about it and learned about how this field really does focus on improving quality of life, on restoring function, on really having to work as part of a team and getting to work as part of a team and address the whole patient, not just one small part of it, from their illness to way out after recovery. It's really a tremendous opportunity and privilege to be able to touch on so many different types of patients and in so many different ways.
Roger, we have a couple minutes left. I'm fascinated by this too. I'm going to go down the line here. We'll start with Stacy. The one, you don't have to, don't mention the name for goodness sake, but the one patient that sticks out, the success story, the one patient that sets the tone.
Gosh, I've been doing this for a long time, so I've had quite a few. We did just recently have a gentleman that I had the privilege of working with. He was absolutely extraordinary. He was featured in the video earlier. He had a stroke that damaged the area of his brain that controlled his swallowing. And we were able to do a video swallow study on him. I think we have that video. And he was actually able to regain his swallow function. So he went from not being able to eat anything at all to being able to eat when he left us. And that was a wonderful accomplishment.
Okay, Maggie, I know you just talked about the man who walked back into your life this week.
I have another one. It was a lady who had Guillain-Barré syndrome, which is a demyelinating, or it takes away some of the surrounding areas of your nerves, and it can cause paralysis. It can cause you to not be able to breathe. So she actually came to us on a ventilator. She needed a lift to get in and out of bed. We couldn't physically lift her because she was so dependent. She could not sit on the edge of the bed, and she progressed to being able to be weaned from the vent. She got her trach pulled while she was here, so she was able to go home without a trach. And she was able to walk without a device by the time that she left rehab. So within just, I want to say, 3 weeks, she made miraculous progress. And it was just an amazing journey to be with her and her family, to be able to witness that and the care that the family brought to her, and to be part of that. And it felt like I was part of their family. And in fact, I still keep in touch with her to this day, and she returned back to work.
That's great.
A very successful story.
There you go. Okay, the one patient that sticks out.
It's really hard to pick just one patient. You're putting me on the
begging
spot.
you, one patient.
But I'll say the one patient that I really learned a lesson from. I had a patient when I was a young therapist who had a spinal cord injury, and he was paraplegic, so he didn't have use of his legs. And he was a tough nut. You'd go into the room, he wouldn't look at me, he would move deadly slow. and he was really tough to treat, but I persevered with him. And he came back 2 years later and came back and thanked me and said that this program changed his life. And he went from doing things that were taking him down the wrong path to completely turning his life around. And he was still in a wheelchair, but he was so appreciative. And I would have never, ever thought that that patient would come back and say thank you.
How about that? Is that something?
Yeah.
Carol, I think we know where this is going.
Well, I have my own story.
There we go.
But mine too was from my younger years. It was an older gentleman who had an aortic aneurysm that ruptured and ended up impairing the blood flow to his spinal cord. And he ended up with an amputation as well as some other things. But just kind of the same thing, watching the progress of the patient. He had such an extended family. So just kind of thinking about how that network of people helps to reduce anxiety and incorporating families into it. And I had the luxury of being able to go to his 50th wedding anniversary party after he left. And it just, you knew you made a difference, but just also to see him back in his own element and thriving with his family. Nothing like it.
Nothing like it. Now, where are you going to school, Adam? Where are you going to go?
George Mason.
George Mason.
Yeah,
all right. And what are you going to major in?
Civil engineering.
Civil engineering.
He graduates in May.
Smart kid. May you graduate. Would you do us a hug? Can you come up here and hug your mother? Yes, you do.
Can I hug Jen too?
Yes.
Thanks, baby. I love you.
All right, go hug Jen. Man, I think we've seen the success of MedStar Good Samaritan and what they've done. I think he's going to leave us with memories here tonight. We want to bring up, I don't know how he follows this. Where's Brad? Brad Chambers, who is the El Presidente of the hospital group here, and he's going to say a couple words. Look at that.
Always good to see you.
How are you,
I'm
Brad?
good to see you. Good to see you. Really, on behalf of everyone here at MedStar Good Samaritan, let's give it up for our wonderful panel tonight.
Yes.
They did a tremendous job. And to all the wonderful staff that we have here at MedStar Good Samaritan, this is truly the heart of what we do. For nearly 50 years, providing excellent care to the community, and at the core has been our rehab program. And I really hope all of you out there can join us next year when we open up our brand new inpatient rehab facility here at Good Samaritan. We're very excited about that. We have a wonderful year-long celebration celebrating our 50th anniversary here at Good Samaritan. And at the center of this is really our beautiful inpatient rehab facility. As always, I want to thank Jamie and our wonderful partners from WMAR. We've been doing these webcast series now across MedStar for 5 years. And it seems like, Jamie, every quarter you and I are together, wherever we are across MedStar. But on behalf of the entire MedStar family, to your family, wonderful stories tonight. Thank you for being here with us at MedStar Good Samaritan Hospital. And I hope everyone comes back and sees us here next year. Thank you so much.